to start with my take-home points so that you can keep these in mind as we go through our cases. I want you to come away from this knowing that genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, and APOL1 genetic testing may eventually help to identify at-risk individuals, but uncertainties exist regarding the clinical implications. So let's get to my first case. This is a 38-year-old woman recently diagnosed with ADPKD in the setting of hypertensive emergency, which presented as epistaxis. In the emergency room during her evaluation for this, she was found to have bilateral kidney cysts and liver cysts. Her family history is notable for a father with diabetes and kidney cysts. He's currently age 70 with a GFR of 55 by report, and he's not on dialysis. She said that she had not been aware that he had kidney cysts because the father has always considered diabetes to be his major medical problem and didn't think the kidney cysts were really important. The patient's current GFR is about 100, calculated from a serum creatinine of 0.75. And her daughter, at the age of 8.5, for a variety of reasons, was actually recently diagnosed with bilateral kidney cysts as well. So this is not meant to be a talk about management of polycystic kidney disease, but just to give you a sense of how I go about caring for my patients with PKD. We're fortunate to be able to get total kidney volume measurements on most of our patients. And this patient's imaging revealed that she falls into so-called class 1C of the Mayo Clinic Erasmus classification of total kidney volume to assess risk of rapid progression in ADPKD. So this is the figure from the very heavily relied upon quote-unquote practical guide for prescription of tolvaptan and assessment of clinical care for polycystic kidney disease patients. And as you can see, one of the major branch points comes at the point of trying to measure total kidney volume by CT or MRI and determination of the Mayo class. So since we had this detailed imaging, it might be a question of why we would need to pursue genetic testing, if at all. And to talk a little bit about the rationale for testing in this patient, I think that the concept of shared decision-making is very important. She was relatively thrown off and shocked by this diagnosis, had been very healthy most of her life, was not aware of her father's kidney cyst issue, was very disturbed to find that her daughter was also recently diagnosed with bilateral cysts. So she thought that it would be very important to have the genetic information available to her to just understand the diagnosis better. So we did pursue genetic testing and indeed found a pathogenic mutation, which happened to be in the PKD2 gene, consistent with a diagnosis of autosomal dominant polycystic kidney disease. So to talk briefly about PKD1 versus PKD2, PKD1 comprises about 60 to 80% of all ADPKD pathogenic mutations thus far described. PKD2, which encodes the polycystin 2 protein, comprises about 15 to 25%. And in evaluations of individuals with a PKD phenotype, no mutation is detected in about 10 to 15% of patients. So-called additional cystic kidney disease genes such as GANAB and DNAGB11 comprise less than 1% of the molecular diagnosis for individuals with PKD phenotypes. So what to do now with this information? Technically, she meets the threshold for so-called risk of rapid progression measured by total kidney volume, and by the practical guide, she would qualify for tolvaptan prescription. Another risk scoring system, however, that's predominantly in use in Europe, assigns lower risk to PKD2 mutations than to PKD1 truncating and non-truncating mutations. So just to remind you that the REPRISE study, which led to the FDA approval of tolvaptan, actually only enrolled individuals whose GFR ranged from 25 to 65. And notably, total kidney volume was not an inclusion criteria for REPRISE. And genotype data from REPRISE is actually not yet available either. So how do you apply these various conflicting pieces of information to make the decision about whether or not you should treat her with the only FDA-approved medication specifically for ADPKD? So this was a study that evaluated total kidney volume and genotype in the CRISP and HALT-PKD studies, where both of these measurements were available. And you can see that there's actually a range of kidney volumes and so-called Erasmus class or MIC, Mayo Erasmus class designations for total kidney volume. So if you look on the right-hand side, you can see the various classes of A through E indicating lower to higher risk, and then the corresponding genotype on the other side, where of course you do see that PKD2 genotype tends to have a more mild phenotype, but that there is considerable overlap in the range of PKD1 non-truncating mutations with PKD2. So there are, in other words, PKD2 patients who do have larger kidneys for, as you might imagine, there's a range of presentations within any of these genotypes. So here you can see that those with PKD2 in the Mayo Erasmus class of 1C did have later onset of kidney failure. But as we discussed, there is a range of disease courses. Interestingly, the rate of growth of the total kidney volume is the same for PKD1 and PKD2 genotypes, meaning that the growth over time is the same, although the sort of starting place is different between these two groups. So you might imagine that using the argument that the attenuation of cyst growth progression by tolvaptan being the main mechanism of disease could still apply in those who fall into the PKD2 genotype and may have a slightly higher TKV at the time of assessment, falling into a risk of rapid progression. For various reasons, this patient prefers not to take tolvaptan, which I actually think is quite reasonable, especially considering all of these factors and the fact that her GFR is very preserved at this time. She personally prefers to use various dietary interventions, and she's still just coping with the new diagnosis and trying to make a decision about what we would like to do in the coming months to years, working together as a team.